Welcome to the second video in the unit on epidemiology. In the first video, we talked about the types of epidemiology that were there and some of the information that we collect for epidemiological purposes. In this video, we're going to talk about how we collect that information. So what are the tools of epidemiology? And then what do we use the information for? Let's go ahead and take a look. So there are two main tools of epidemiology that go hand in hand when we're talking about epidemiology of infectious diseases. The first are the clinical microbiology labs. So these are the diagnostic labs where whenever you take patient samples and you send them off to be tested to figure out what pathogen and what infection the individual might have, these are where those samples go, and these are the labs that are doing the diagnostics to send the information back to the healthcare professionals so they can treat the patient. The key is that these are the ones who are identifying what infectious agents are in the populations. And it's that identification that's the first step and the first tool we need for epidemiology. You can't look at how many cases of a disease or how many new infections you have if you can't identify the actual infections that are happening. The second key piece is the surveillance. And so this is collecting that data from the labs, so taking those identifications and tying it to other demographic data. So where are those cases located? So what is the GIS, the Geographical Information Systems? How are we mapping that onto, say, state maps and maps of the country? And demographics, who are these people? And that's how we get that person, place, and time of that descriptive epidemiology. We can also now do surveillance using molecular techniques. And so this allows us, one, faster diagnoses, so we can get the identity of the pathogen quicker, but also more detail. So we can look to see, is it the same strain? So if you have a bunch of E. coli cases and you're trying to figure out, are those connected to each other? You're going to want to know what type of E. coli is it? So what strain of E. coli? There's lots of different types of E. coli out there. And by doing the molecular methods, you can actually say, yes, these are all the same type, which means they probably all contracted this disease in the same way or from the same source. This is allowed and happens because we have what are called reportable diseases. And so there's a whole table, you can see it here, of diseases that if a patient gets diagnosed with one of these, then the clinical microbiology lab has to reach out to the state public health department and say, hey, we have a case of botulism, or hey, we have a case of gonorrhea. And so a lot of these diseases on the notifiable list are things that are either pretty contagious, and so they're spreading through populations and the public health department wants to know about it, or they're things that can be highly virulent, and so we need to make sure that we're notifying people that these virulent diseases are in the population. The public health department then takes those reports and can build this surveillance and build this collection of information to do descriptive epidemiology and analytical epidemiology with. So as you're doing surveillance and you're collecting this information, what are we using it for? One of the big things is to build what are called epidemic curves. So if you plot the data over time, you can start to see, oh, we're starting to have an epidemic happening. So this is where you're comparing what are the normal endemic levels and are we going above those endemic levels and moving into an epidemic. As that starts to happen, you can actually look at the shape of the curve that forms to learn something about the pathogen, learn something about what's happening in the population. So point source epidemics, things where the pathogen's coming from one given source and is infecting just kind of a small number of people. These are usually associated with outbreaks, and you can see the curve there kind of just goes up and back down. These are the types of things we see with, say, food poisoning, okay? Or if there's contamination at a restaurant. We see this kind of peak of people that get sick, and then we identify that it's happening, and the people stop getting sick. We clean up whatever the problem was. So that's a point source epidemic where it's coming from one single source. The other type of epidemic curve we see is called a propagating epidemic. This is when you have a contagious pathogen that's being spread from person to person. So we can see in the graph here, we originally had a couple people who were infected, but those couple of people spread it, and then we see a larger group of people that are getting infected, and those people had been walking around spreading it, and so this is as the disease builds in the population. When you look at these types of graphs, you sometimes will see these different size peaks, but they're not always necessarily this clean. So for example, this is the graph of coronavirus in Utah. And you can see early on, so here's our kind of one case, and then a couple days later, we get a smaller group spread to the larger group. Hey, you can see that pattern happening at the start. When you look at the overall spread, we can see that we kind of go up and down a little bit, and then we get this blip now as things are starting to reopen. Um, but this is a sign of a propagating epidemic. You don't always get the nice peak and then a bigger peak and then a bigger peak. Sometimes instead you kind of get this curve that's going up and going up, but you don't get the nice clean valleys and peaks. The other key with these types of curves is the peaks don't always get bigger. And so you might see them getting bigger and then they start to go down some, and then they might get bigger again, or they might go down some. The reason for that is we'll see this continuous one peak to a larger peak to a larger peak if there's no public health interventions. But the whole purpose of doing things like quarantine is to stop people from being able to spread it to other people, which means those numbers should go down. It's still a propagating epidemic because the disease is continuing. We didn't get the sharp kind of up down that we see for a point source and then nothing. But we might see something where it went up and then it kind of went down and just continued for a while. That's still a propagating epidemic because it was still being passed from person to person. So you look at these epidemic curves, you're collecting this information because you actually want to use it. And so you want to use this surveillance or something. What are the types of things that public health departments and epidemiologists are doing? Well, they're determining the magnitude of the problem. Hey, how many cases are there? How big of a problem is this in our population? They're looking at the geographic distribution of those illnesses. Where are they happening? This is allowing them to detect those epidemics and evaluate control measures. Okay, so for coronavirus, we've implemented quarantines. Has quarantine slowed the spread of the disease? Are we seeing the R naught? So how many people is being spread to from one infected individual? Are we seeing that go down? And we are, which tells us that these control measures are working. Okay. We want to monitor changes in infectious agents. So how are the pathogens themselves in the population changing? This allows people to facilitate planning. Where are public health dollars going to be spent in the community and what diseases are they going to be spent on? And it also allows you to do things like track hospital-acquired infections. And so we've been talking about kind of public health and epidemiology for entire populations of the state or the country, but you can also do epidemiology on a smaller scale. And so all hospitals, all medical clinics are always keeping track of their own data and looking to see in their own individual population what is the health of population and what diseases are spreading through their facilities. That's looking at hospital-acquired infections. So hospital-acquired infections, which are also known as nosocomial infections, are a big deal, and this is why healthcare facilities pay attention to them and track them. 5 to 10% of hospitalized patients develop an HAI every year. That means up to 10% of the people that go to the hospital for some other reason pick up an infection while they're there in the healthcare facility. It's about 1.8 million people every year who are getting these HAIs, and almost 100,000 die from them. That's a number we really need to bring down, and it's why people track and pay attention to these HAIs. So the epidemiology in the healthcare facility is really the job of infection control nurses and ID doctors, or infectious disease doctors. This is actually the job that I did at Intermountain when I was there for a couple years before I started at UVU. What these people are doing is looking to see if we're having an abnormally high number of a particular infection. So if one unit is all of a sudden seeing higher cases of MRSA in their patients, that's a flag that something might be going on. And so what infection control is going to do is look to see, okay, are these patients infected with the same isolate or the same strain? Remember, bacteria can kind of vary widely in their genetics. And so if they're all genetically the same strain, that's an indication that they may be transmitting it from patient to patient somehow. And if that's the case, we want to figure out how. And so we're going to look to see that kind of who, what, where. Have the patients come into contact with any of the same hospital staff, with the same patient, so where the patients may be spreading it to each other? Have they come into contact with the same instruments or the supplies? And so what we're trying to do is find connections between the infected patients. And to do that, oftentimes the researchers and the laboratory folks will come in and swab different areas, surfaces. They'll look at, a lot of times, things like stethoscopes or nurses' hands. They're trying to see if they can find places where the microbe might be that are connected to the transfer from patient to patient. And then they're also going to look to see, for those surfaces, are they being maintained properly? So are they being cleaned the way they're supposed to? Are infection control measures being maintained? And the reason that hospitals and clinics spend so much time on these tracking of HAIs can really be highlighted here in this table. So if you notice, if we look at urinary tract infections, the first one here, 40 to 50% of all urinary tract infections that people have in hospitals, they got in the hospital. That's a really high number. This is a lot of times due to catheters, and it costs on average about $900 more to treat each one of those patients. About 20% of people who get diarrhea in the hospital picked it up in the hospital. This is often C. diff. That's going to cost you a little over $11,000 for each patient. 20 to 30% of surgical wound infections are hospital acquired. This has a lot to do with the surgery itself and kind of the patient's underlying diseases, but each one of those costing over $20,000 per patient. Up to 20% of pneumonia cases are happening by hospital-acquired infections. Most of these are what we call VAP, or ventilator-associated pneumonia, and those are extremely costly because they're hard to treat, about $40,000 more per patient. And similarly, septicemia, which tends to be caused if you have central lines put in, about $45,000 extra per patient. And this is due to patients being in the hospital longer. They're there longer, they're getting sicker because they were admitted to the hospital in the first place, and that's really something that needs to be watched and needs to be taken care of. So infection control measures are really what the epidemiologists have put in place to say, how can we try to prevent those hospital-acquired infections? And these are straightforward things like hand hygiene, so washing your hands before and after you interact with each patient, wearing the proper PPE, so your personal protective equipment, which depending on the patient may change. And so you'll often see that patients that have certain infections have different PPE you need to wear around them to protect both yourself, and then also so that you're not transferring those infectious agents to another patient when you go to interact with someone else. This is also why we have aseptic technique, so making sure you're using sterile equipment, cleaning off sites before you insert catheters. And it's why there's disinfecting protocols for room surfaces. So hospital cleaning staff is really trained on how you should be washing down the room surfaces, what high-touch surfaces need to be disinfected, and those types of things. They are going to conduct outbreak investigations like we were just talking about as they're necessary, which means they have to really maintain good patient records to do a lot of this disease tracking. And all of these things are meant to try to really limit that spread of infectious diseases throughout a hospital or a healthcare setting.